to remind you, in case you forgot, it's based on use of barriers, okay? Typically pressure and temperature. Now, temperature, obviously you could use a hot pack or some kind of thermal device. The old osteopaths used to use these diathermic lamps, and they'd kind of put it over there and let it heat up, and then they would do what they would do. That was kind of their passive way of warming the area up, right? They just put a heat lamp over the area, and then they would go and do what they're going to do later on with it. But we can create the heat with what? With our hand. Either, well, friction, right, creates, but that also does what? Well, it can be irritating, especially if it's an area that's sore. You can create, sometimes it can be useful, like, you bang your arm, you're like, ooh, and you rub it, and what you're doing basically is you're stimulating other nerve fibers to buffer those pain fibers, right? But generally, what we're trying to do is that whole afferent-efferent relationship thing. We're trying to impact what the person is experiencing in a way that it becomes more pleasant, more gentle. So you were saying, Rob, about, she had a lot of pain, the patient had a lot of pain, and you remembered, try to move in a way that's slow and steady and doesn't flare up the pain. You're allowing that afferent-efferent neural loop to what? To calm down, to wind down, okay? But we might use sustained pressure. It could be in parallel or perpendicular to the muscle fibers. Sustained pressure, and most of us really, most of our body is fluid. Most of our body is fluid. So if you put pressure into fluid, does fluid compress? No, it pretty much is non-compressible for the most part. And the pressure that you put in, energy is created or destroyed, it simply changes form. So mechanical pressure becomes thermal energy, becomes heat. And by doing that, not activating any proprioceptors or anything, just physical pressure into a relatively fluid-based space, temperature starts to increase. As temperature starts to increase, the idea from a theoretical model is that some of the cross bridges and the bonding of the fascia start to break, because you're overcoming their ability to adhere. And as that starts to break, that releases heat, and then it causes a gel to sol kind of relationship, and as a result it softens, and you start to experience what? Fascial creep. That's kind of like a molecular model type of way of fascia working. Another way that it's thought to work, especially if you're dealing with over muscles, is that as you put increased tension into a muscle in a sustained way, that stimulates a certain proprioceptor. Which is the name of the proprioceptor? Golgi tendon organ, right? Golgi tendon organ, intrafusal or extrafusal? What does fusal mean? In the muscle or outside the muscle? It's extrafusal. It's outside the muscle. It's not within the muscle belly. It's in the musculotendinous junction. Sensory, motor, both, neither. Which does it have? Sensory only. Its job is to keep track of the amount of tension on a muscular tissue. When that tension increases, it starts to send back feedback information to potentially think about what? Decreasing tension, especially if it has any kind of thought that it might get injured. So Golgi tendon organ stimulation causes involuntary muscular relaxation, which is something that you would want in somebody that has hypertonicity and you want to get a myofascial release kind of process going. Okay? So the idea is that myofascial treatment, what are you doing? How does it work? Well, what am I looking for? I'm looking for bind, ease, or balance points. Okay? I'm checking you these ways. Once I find what I need to do, I can choose to go into the barrier or go away from the barrier, sustain pressure. I might be working from a molecular kind of reconfiguration to allow fascial creep to occur because of the structural dynamics of fascia. And I might be also triggering a Golgi tendon organ apparatus. This is why we do myofascial release slowly. What happens if we do it quickly? What happens? If we get in there and we just give it a quick rub, quick boom? Well, that's through what? You get a myotatic reflex arc. That's stimulated through what proprioceptor? Muscle spindle. Muscle spindle, intrafusal or extrafusal? Intrafusal. It's actually specialized types of skeletal muscle. Afferent, efferent, sensory motor or both, neither what? Both. It has both. It has fast and it has slow.